All right. Well, welcome to the folks that decided to hang out to the telehealth lessons learned and looking forward. My name is Ellen Beasley, and I'm the Faith and Community Initiatives Program Manager at IEI. So super excited to be here today. We have an incredible panel with us today, and we'll have time for questions at the end. And while they're walking up and getting seated, hello to my family on the live stream that told me to send the link and let them know when I was speaking today. So our breakout session is being live streamed on IEI social media pages, and this session will be recorded for later viewing as well. So you can send it to all your friends afterwards. IEI staff will be taking notes to add to our collaborative Google Doc on Band NC's Resource Hub. And I'm so glad to have our partner, Dr. John Graham, serving as our moderator this session. Dr. Graham is the president and co-founder of the North Carolina Telehealth Network Association, NCTNA. And NCTNA is a nonprofit broadband provider for nonprofit and public health care and public health providers across the state of North Carolina, with a focus on rural North Carolina. So you are able to learn more about all of the panelists on our app, and make sure to write down your questions throughout their session at the end. And welcome panelists. Go and get started.
Is that better? Yeah, you can hear that. Okay, let's see, here's the clicker. So we're going to talk a little bit about telehealth today. We've got a great panel here, and I'm going to let them introduce themselves as they begin to talk to their stories. But and we have, I think, everybody's here. So that shows you sort of where everybody's from. And again, they could talk a little bit about their organizations as they talk about their stories. The first thing I'd like to do is just talk a little bit about telehealth trends. I'm going to just spend a few minutes doing that, and then we'll get into our stories and case studies in terms of the work that's actually being done on the ground. So I'm going to stand up over here so I can actually see the slides, and then we'll just move forward through there. Oops, wrong way. So these, again, are the different participants on the panel. And then some quick facts. Everybody knows what telehealth is. It's the use of telecommunications tools to provide health care. Usually there's a physician or a provider in one location, and then the patients are in other locations. Since the onset of COVID-19, we've seen a rapid expansion in telehealth. Prior to the COVID pandemic, about 2% of our patient visits were telehealth visits. Many healthcare providers weren't providing telehealth at all, and most providers were only providing telehealth in a few selected specialties. Then COVID happened, and I was actually talking to a friend of mine in April of 2020, and he said over the course of March and April of 2020, the use of telehealth grew by 30 times, 30-fold, not 30%. So it was massive. And then if you look at the overall COVID pandemic period, on average, telehealth grew by 38 times. So it went from almost non-existent to being a predominant form of patient visits. In fact, during the height of COVID, about 80% of our patient visits were through telehealth. So it was a rapid introduction. Of course, there were lots of hiccups along the way when you have that kind of explosion in use. For example, there were problems for physicians and providers in terms of integrating the patient information where they were seeing patients via telehealth into their electronic health records, things like that. On the patient side, there were problems with connectivity and digital literacy, things like that. And yet, in the end, both sides, the providers and the patients, were highly satisfied with the experience. So through that experience, it became clear that telehealth is here to stay. And so it's continued to be a very important, and as tools and procedures improve, in all likelihood, it's plateaued. The usage has plateaued at this point, but it may very well grow over time. So here's what it looks like when the pandemic hit. Massive spike. So that's in the peak of the spike was in April, May of 2020, and then began to see a pretty sharp fall off, and then you see it plateau. I'm going to talk a little bit about how this sort of has worked for different covered groups in a minute, but I wanted to talk a little bit about the specialties that have seen the biggest increase. So these are different clinical classifications. So you probably can't see the writing; it's a little bit too small. But you see one specialization has been just outdistancing everything else dramatically. Even the others have grown substantially relative to where we were. The one that's been so extraordinary is behavioral health, as one might think. And you'll see lots of research being done on this, and there's a great deal of patient satisfaction. And we have a number of behavioral health providers here who can talk about the experience and how things have really changed since the pandemic. So I wanted to track post-pandemic, and I wanted to get the most recent data I could get in. And really, CMS is the provider of that information. So the data is not fully representative of the overall population, but the trends track very closely with what you would expect from the overall population. So you see a spike during 20, and then you see it dropping, plateauing, dropping, plateauing, and now it's plateaued now, and it's about 15% overall in terms of overall patient visits. In terms of covered populations, looking at race and ethnicity, down at the bottom you see the color codes. The two highest adopters, interestingly enough, are Asian Pacific and Hispanic, which is surprising. The reason for that is that, of course, telehealth is often used vis-a-vis the internet. It's also used vis-a-vis mobile phones. And what we find is that for the minority groups that use relatively higher or have adopted telehealth in relatively higher numbers, it's because they're doing it over their phones. Phones are a useful medium or technology to use, but in some ways it's not. It's certainly good for things like consultations and things like that. For other things where you need much sharper video and things like that, it may not be as good. Here we have the trends by Medicare entitlement. The bottom line is aged, the middle line is early renal disease, and the top line are disabled. And so we see the disabled actually have a very high adoption rate on the order of close to 30%. And then you drop down by each of the other groups. The lowest adopter are the aged, which is a little discouraging because we have all these lots of telehealth solutions that relate to aging in place and really making a difference there. So hopefully we can see that that adoption rate increase over time. And then we have by age group, and again, you see that the oldest from 65 to 85 are also the lowest level adopters. Now they're at about a 10% adoption. The people in essentially the working age category from 0 to 64 are much higher adopters of telehealth. And it's interesting, this number sort of hides the fact that the lowest level of adoption is actually done by the youngest people from 15 to 25. They actually have the lowest rates of adoption, which is also interesting given their interest in all things electronic and digital. Oh, and that's it. So just a little information on the trends that have been happening in telehealth, et cetera. Now we're going to get into some discussions with our panelists about the work they're doing on telehealth and on digital literacy related and health literacy related activities. So let's begin. I'm going to ask Ellen to kick this off. We'll talk a little bit about lessons learned and the experiences that they have had. So let me begin with our initial question. What is your organization currently working on, and what are telehealth access needs specific to different communities you work with?
Yeah, thank you. Good afternoon, everyone. My name is Emily Hamilton. I'm the quality manager and RN at Vecinos Farmworker Health Clinic. Just a little background on the organization. We are physically located in Western Carolina University's Health and Human Sciences building. We have been providing mental health and primary care medical services to the migrant and seasonal farm workers of the 7 southwestern counties of North Carolina since 2004. Our clinic has two night clinics a week. Monday, Wednesday, we attend patients in person there on Western's campus, and then we have a mobile unit that goes out to 20 some different migrant camps in the various counties of southwestern North Carolina. In the past 2 years, we've also opened our doors to not just farm workers, but other underinsured and uninsured individuals, our specialty being providing culturally competent and linguistically competent care for primarily Latino patients. So as far as what we're doing with telehealth, like many organizations, high utilization of telehealth during the pandemic. In quarantine, it was a great way to provide services to migrant patients who could not receive them in person. What we found during that time was both providers and patients really liked telehealth, and that it helped address some of the other social determinants of health or barriers that prevent our patients from coming into clinic and receiving services in person. So a lot of our patients, we have patients camps that are an hour and a half away from our physical location. So we have farm workers that are working from sun up to sundown, get off work at 7 or 8, don't have transportation to get an hour and a half to our clinic. Or if we are able to provide transportation, they can't physically get to the clinic until our last appointment is 8:30. So they can't make it in time. So telehealth was a fantastic way to make, especially for acute issues, healthcare and mental health services available to patients who, for transportation or schedule reasons, could not come in person. So we've actually, last year, we started incorporating a weekly telehealth schedule. Apart from our Monday, Wednesday in-person clinic, we have a telehealth schedule open every Tuesday and Thursday. We're very fortunate now to have a full-time bilingual provider who mans that schedule, or womans that schedule, I should say. It was a challenge before that. We did have, just talking about some of the barriers, having to coordinate telehealth with a English-speaking provider and having an interpreter on, because most of our patients are Spanish-speaking, having to coordinate three-way calls with an interpreter and a provider could be a challenge. So we're really lucky now to have, most of our providers are volunteer, but we have a full-time bilingual provider who's able to man that schedule. It's extremely useful to us, as I mentioned, addressing barriers to patients coming in person, also because we have limited availability of appointments. The physical space we use is donated by Western Carolina's campus on Mondays and Wednesdays. We don't have other opportunities to attend to patients in person, so that allowed us to open up more appointments to our patients. The next thing we're looking at, we're really trying this year to pilot incorporating telehealth more for chronic disease management, especially for our migrant patients. One of our biggest challenges is making sure that our uncontrolled diabetes and hypertension patients, especially those who physically feel fine and they're an hour and a half away from the clinic, and we're telling them they need to come into the clinic once a month to titrate their blood pressure medication, ensuring that they come in physically is just a logistical nightmare, both for them and for us. So we're really trying to work with our community health workers who are going out, educating patients on how to self-manage, check blood pressure, check blood sugar at home, and then the provider can have a telehealth visit with those patients to check in on symptoms, titrate medications, check in on their measurements. So those are a couple of the things that we've been doing with telehealth since the pandemic. Am I talking too long? Is it okay if I go into some of the barriers? Our biggest challenges, especially in the context of our migrant and seasonal workers, is privacy. So a lot of the housing situations of our workers, we have many workers living in small quarters, all close to each other, beds right next to each other. A lot of times for a patient to get privacy, they have to go outside in the cold, in the mosquitoes, in the rain. It goes without saying, some of the camps we serve, to get to them, you'll drive up the mountain road until you lose internet signal, and then you drive 45 more minutes. Like, it's deep into like no signal. A great way to address this issue, working closely with the NCFHP that had the Internet Connectivity Project, which involves lending out hotspots to migrant camps to give them accessibility to high-speed internet in order to be in communication with family and in order to receive telehealth at these areas that don't have cell service. But even with those hotspots, only so many people on the camp can be connected to those at once. A lot of people are connecting to talk to their families during evening hours when we're trying to do telehealth. So a lot of like the video telehealth is really, really difficult to have good enough signal, even with the hotspot, to make those reliable. Another big issue we have is a lot of our farm workers don't have US phone numbers. And a lot of right now, with the end of the COVID emergency response and the HIPAA enforcement discretion ending for telehealth, and having to like make sure that we're using HIPAA compliant platforms, the ones that we've accessed so far or have been able to afford don't accommodate for non-US phone numbers. So that's been a huge challenge. The best option for non-US phone numbers for us has been the application WhatsApp, but it's not HIPAA compliant. So we've had a huge challenge with finding an alternative that's also HIPAA compliant. So yeah, that's just a little bit of the challenges we've had and what we're doing with telehealth. And I think I'll go ahead and pass it on so I don't take up all of our time.
All right. Hey, y'all. I am Courtney Moore. I am with the North Carolina Department of Health and Human Services, Office of Rural Health, Health Information and Technology Telemedicine Program. It's a mouthful. I've only been in this role for maybe half a year, so I may draw on previous experiences. So if you hear me talking about work with agriculture, know that there was a previous role there that really played into getting me to where I am now. At the Office of Rural Health specifically, our team has funding from the Office of Digital Equity and Literacy to increase digital health and digital skill capacity in rural underserved populations statewide. Part of that includes a Train the Trainer program that was originally geared towards community paramedics who were going to homes for things like hospital at home programs or to decrease readmissions into the emergency room for patients managing chronic disease, among other issues that are facing our rural populations. With that Train the Trainer program, we really saw that maybe some of the curriculum wasn't there to accompany the Train the Trainer, so we took a step back and have worked really hard on putting together and pulling together resources focused in digital skills that include not only being able to access a video conferencing platform to access telemedicine appointments, but also being able to access and use a patient portal, being able to understand what you're finding there, how to communicate asynchronously with your doctor, as a lot of the issues that we were encountering were scheduling issues. I can't get to the doctor during the hours that they're open, but I have a question. Educating the population on how to use their patient portal to send that asynchronous message to their provider. Looking at that, we looked into some of the health literacy. Sorry, that's catching this out of my eye there. Looking at health literacy levels and patients' understanding of how to manage chronic disease, not being able to get in or go in to titrate blood pressure, managing their blood sugar, doing some general patient education among hypertension and diabetes specifically, just as those rates are substantially higher in our rural populations across the state, but also looking at when is it appropriate to use the emergency department versus urgent care versus a primary care provider. What does your primary care provider offer you? Again, there's an accessibility issue there with insurance coverage, but looking at that, we also have taken it one step further and are looking at educating patients on their insurance and what their insurance covers, especially among the Medicaid expansion that the state has recently gotten. There's now a large population of patients who qualify and are getting enrolled in Medicaid, but aren't necessarily sure what Medicaid covers, how Medicaid works. So bringing the education to the patient, started really talking with community members, and we're really listening to a lot of what we were hearing about community paramedicine programs and finding that these are often in counties a one-man or one-woman show, stretched thin, covering large rural counties with patients who were apprehensive to use telemedicine to start with. They were like, this education's great, but if I bring it up with my patient, they're going to shut me down because they don't want to talk about telemedicine. So we have taken a step back and are looking at how do we frame this in a different way? How do we frame this for the digital skills that you need to improve a resume, to potentially land a job? How do we do this to use telehealth conferencing platforms or Zoom, things of that nature, to FaceTime or get in contact with family members who you may not be able to see regularly? Using those to implement some skills, increase their interest levels so that they're becoming more comfortable with the technology necessary for telemedicine, so that hopefully down the road they've developed this trust in a digital system that allows them to move forward in using some of these telemedicine platforms. So on the community paramedicine level, we're looking at smaller scale, 1 to 2 people education levels, which is grand. However, I very much believe in meeting people where they are, and not everyone is getting visited by a community paramedic, but there's other organizations in these counties. For example, North Carolina Cooperative Extension and their family consumer science agents and digital skills educators that are also being funded from the Office of Digital Equity and Literacy to do some of this work in rural communities. How can we partner there to use the trusted safe space that Cooperative Extension has to offer in a good area where patients and individuals would maybe seek out education, or family consumer science agents are able to go to these other aging populations in different demographics. Also, hopefully a little bit further down the road, we're still, really early in development of this. We're hoping to get this also available to be taught by faith-based leaders in churches, whether that's a preacher, a deacon, a bishop, whomever, or a physician, a nurse, a member of the congregation who's maybe willing to volunteer some of their time to do some of this health education to hopefully increase these literacy levels so that our patients, much like was just said, can manage their blood sugar, take their blood sugar, get that into like a remote patient monitoring type system, and then have consistent telehealth follow-up with the physician so that they're able to get the access and chronic disease management that they need without having to go an hour, 2 hours to the physician. I'm from the rural eastern part of the state, so that can even up to 3.5 hours just to get to a primary care provider, and already inundated health systems that don't have the capacity to serve the patients at this level. So how can we put all of these different pieces together to make it less of a disjointed system and be able to provide care to our patients, but also increase the patient's involvement in their own care and get some of that patient autonomy up so that our compliance rates increase as well.
Thanks, John. I give you full permission to take my mic away if I babble too much, because I have a tendency. So my name's Steve North, and I'm a family physician. I'm board certified in addiction medicine and adolescent medicine as well. And I have been working to develop, build, sustain research, write about telehealth and now virtual care since 2007. Through the Jim Bernstein Health Leadership Program, sort of in a tangential to the Office of Rural Health, I began developing a school-based telehealth program in 2007 that launched in 2011. And that school-based telemedicine program has evolved significantly as technology has evolved and as acceptance of both telemedicine and schools as a site of care for kids to receive medical care has evolved. When we first started in 2011, we had an otoscope that looked like a phaser. It had a light source coming out of it. It had a video source coming out of it. And after about 3 minutes of using it, it got hot and you needed to put it down, and it ran into a PC and we had to jump between a wide variety of programs. Our school-based program has expanded from 3 pilot schools in Mitchell and Yancey County in 2011 to about 110, 120 schools in 10 counties, predominantly rural counties, across North Carolina. And over that time, the technology has evolved that we now use a handheld device that is an otoscope, a stethoscope, and all the video is done through an iPad that has really changed our ability to move from a $30,000 telehealth cart to a $2,000 handheld device, and that really drove our expansion and access to care. So that's where I sort of got started in telemedicine and continued to be the medical director of that program that is now led by an amazing nurse practitioner, Tanya Hensley, and a great executive director, Amanda North, who became my wife long after we started working together on that program. I have had a bunch of different roles, but currently I am the Vice President of Medical Strategy for Eleanor Health. And Eleanor is a full-service addiction medicine practice with psychiatry, addiction medicine docs, behavioral health through therapy, peer support services, and nurse care management. We began building as a bricks and mortar practice in September of 2019. We opened our first practice in Mooresville, North Carolina. The pandemic came, and we helped lead the way of moving addiction medicine from being a come in, you have to do your urine specimen in person in the clinic, to being a virtual program. About 95% of our visits are entirely virtual now, which has really expanded our footprint. Yesterday, I saw 20 or so community members across the state of North Carolina and in Louisiana, predominantly in rural areas, on their phones, outside of their trailers, outside of their job. And the amazing thing about that application of virtual care is that I get this little look into their home life or into their workplace that I wouldn't have in the office. You know, when Mrs. Jones would come down from prior to, so I also spent 15 years at a rural health center in Mitchell County. And so when Mrs. Jones would come down, she'd get dressed up nicely to come to the doctor. But when you see somebody in their home, you see them more how they are every day and the resources that they have. And that is a tremendous advantage. And I really like that. There are limitations to what I can do in that setting. Unlike the schools, I can't listen to hearts and lungs. And this is what has really now become the predominant form of telehealth, is just a video visit, versus what now people call advanced telehealth, which is when you have peripherals. And I see the potential of telehealth really moving to what Courtney began hinting at, this sort of hybrid care, where instead of seeing a patient who has diabetes and other complications every 3 months in the office because I have to get that hemoglobin A1C and check their blood pressure, I now see them twice a year in person to do a foot exam, but otherwise I have more frequent touches with them, and I'm able to have a better sort of arc of care with them through the use of remote patient monitoring with their now, embedded Dexcom glucose monitor. I can read them every day, and I see them in their home. And maybe I don't see them as frequently, but our nutritionist does, our nurse practitioner does, our nurse care manager, and they're more closely connected to their care team. And because we're removing that barrier of distance. In the school setting, by removing the barrier of distance and giving kids access to care at school, 94% of our kids in the 2023-2024 school year returned to class after the medical visit. And if those kids had to leave school and mom, dad, grandma had to leave work to pick them up and go to urgent care or the emergency department, or possibly getting an acute slot at their regular doctor, it would be incredibly disruptive and they would not come back to school. About 83% of our visits last year were acute. So I'm currently using telehealth in 2 different environments, but really it's about access and it's about engagement. And the other thing that we see at Eleanor with our care via telehealth is that our community members who are struggling with a substance use disorder or in recovery stay in care longer. They're retained in care. And so the average length of care for somebody with an opioid use disorder in a practice is 6 months. People change quite frequently due to a wide variety of reasons. We see our average being 12 months currently. And we have community members who have been with us since 2019. I see one personally on a regular basis, and he is thriving with care in this environment. And it's just amazing. Telehealth is not the answer for every health solution. My wife likes to point out that just because you can provide access to care doesn't mean that there are more slots to see the cardiologist or the kidney specialist. And so telehealth is not a panacea. The no-show rate is much lower in virtual care because there aren't the barriers. And I think that that's where we see medical professionals, health professionals in general, enjoying their telehealth care perhaps more than in person because people come and are more engaged. I think that's good for now. Yeah.
It's great. Kevin, did you want the clicker for your slides? You click the down button for your slides to advance. Okay.
So I'm Kevin Parker, and I am the regional manager for Western North Carolina for CareNet. And just to be very brief about CareNet, we are part of Atrium Wake Forest Baptist Health. And CareNet's been around for over 100 years now, just over 100 years. And CareNet's genesis was in the pastoral education department of Wake Forest University, of training pastors to care for their congregants' emotional and psychological and spiritual needs, that then grew into us taking care of pastors, that then grew into us taking care of pastors in their congregations. And then in the late 70s, CareNet transitioned into what it is today of community behavioral health. And so there's 6 centers across the state of North Carolina, and we are mostly located and serve rural communities. My area here in Western North Carolina, we are officially, our catchment area is 7 rural counties, starting around Burke and going to Buncombe north and south. But due to telehealth, that number has expanded to 12 counties in North Carolina, and telehealth has provided us that platform and that conduit to reach more people and to reach more rural areas. And especially true to CareNet's mission is to go where services don't exist and where we are called. And so telehealth has been, Steve, to your point, not necessarily a force multiplier for us, but it has created portability. It has created accessibility for many patients that otherwise would not have access to behavioral health. True to John's slide of behavioral health and where we've seen the greatest need, I would say that is true. Prior to March of 2020, in my world of providing outpatient psychotherapy, telehealth was something we dreamed about. We occasionally talked about and brainstormed what it could look like. And but until March of 2020, it wasn't a reality. And that day in March, when the world stopped turning, if you guys recall, we had to completely retool our business, and we were back up in operation in less than 2 days seeing patients. And we had a pretty steep learning curve of learning what platforms to use and what we could use and couldn't use, learning it ourselves as providers, teaching our patients, and then navigating all of the unique challenges of providing teletherapy in rural parts of Western North Carolina. And that has to do with broadband accessibility and bandwidth, and who has access and who doesn't. And so some wonderful things that we have been able to do through all of this is to form partnerships. And that was with schools early on to allow us to use their parking lots for free Wi-Fi, so patients could get access to us, to partnering with, we've seen it expand into home health and public health nursing, community nursing, of allowing them to take an iPad with them. So while home health is working with the patient, we can have a session with the patient. And we've even seen it expand out into working with our primary care physicians that statistics show us constantly provide around 60% of all mental health care. And providing greater access to our primary care physicians in rural areas, of partnering with them to take that same electronic platform into their office and meet with them and the patient together. And so we've had a number of just wonderful successes. Again, it's been a tool for us. And I had some slides that really mirror John's slides he showed earlier with trend lines. And those specifically showed a mirroring, John, of what you had demonstrated. In 2020, there you go. The data is a little skewed, right? Because there was a learning curve in 2020 of, well, we didn't know how to code, and there wasn't a way to code insurance claims for telehealth. And so that the 2020 data The blue, which represents telehealth claims, is really in like the 90% of that figure. But since then, as we've gotten better and as insurance and policy has started to match where we are, we're around 30% is kind of what our mix is so far as telehealth and face-to-face. But that certainly mirrors, John, what you had. I was in I do some work for the state around medical policy, and in a recent meeting, had a conversation with them of, hey, what if Medicaid claims data, what's it showing telehealth? And it was around 30%. And so certainly mirrors that data, John, of what you showed, what the state shows, and people are accessing it, and can certainly talk more about challenges and trends and things as we go along.
Sure. Yeah. Okay, great. Very interesting. Our next question is, not only are there technical challenges with people getting connected to their physical and mental health providers, but many people are reluctant to receive care online. How do you all talk about the cultural conflicts and the changing healthcare norms when discussing telehealth with providers and patients? Emily?
Yeah, thank you for that question. So I would say with our providers, the biggest challenge came around collaborating with our providers, many of whom are volunteer only with us every 2 weeks for 4 hours in the evening, really collaborating, communicating with providers about establishing our internal processes for defining what is appropriate to schedule as a telehealth versus what needs to be an in-person visit, training our support staff who are scheduling the appointments and communicating directly with the patients, like what kind of situation is appropriate, what kind of situation does the patient need to come in person for, and then educating our providers too on what kinds of visits they can refer for follow-ups to be telehealth. So like a diabetes patient newly initiated on insulin, like maybe they want to do a 2-week check-in to see how is the self-administration going? What are your home blood glucose levels? Can we titrate your insulin? And educating our providers, like, this is a resource you can use. You can forward patients to us or put in a follow-up visit for your patient via telehealth, which allows your patient, reduces the risk of no-shows, as mentioned, and also frees up appointments in the clinic, which we have limited slots, limited days that we can attend to patients. So really just that education on the benefits of telehealth and making sure that all of our staff are on the same page as far as what is appropriate for telehealth and what isn't. I wouldn't say we've had reluctance from patients overall. I would say telehealth is extremely appealing to our patients. As your trends were showing, I was not surprised that some of the larger users of telehealth services are the Hispanic population, especially our undocumented patients. Like they're putting themselves at risk every time they leave their homes. A lot of our patients, they might have cars, they have access to cars, but they or anyone in their family, if they're undocumented, can't legally hold a driver's license. So a lot of our patients, if they're driving to our location from Franklin or even Tuckasegee, Silva, other 45, 30-minute drive, if you get stopped by a police car, whether this is true or not, a lot of our patients think that if they get stopped for whatever reason and they don't have a driver's license, that they may be deported. So just telehealth in general kind of like removes that level of kind of fear of going out. And then a lot of our patients, we have moms who have like 3-4 children who don't want to have to put all 3-4 children in their car and drive them to the clinic. They can have a telehealth from home without having to worry about childcare. So there's just a lot of barriers that telehealth overcomes for our patients. And we have actually had to do education with our patients too, especially after COVID, that things have changed. You can't only be seen via telehealth now. You do have to come in person at least once a year. And certain issues that patients call for, educating patients on, that's really something the provider needs to lay eyes on you. We need to do blood work. We need to do a UA to confirm if there's an infection. So I wouldn't say we've had reluctance from our patients. We don't ever like push it on patients. We offer it as, this is an alternative. You might be able to talk to a doctor sooner based on our telehealth availability versus coming in clinic. I would say one of the biggest kind of conversations we've had to have with patients, kind of going back to barriers a little bit, a lot of like the HIPAA compliant platforms, the way they work is they'll often like text a link to patients and the patient has to click on that link on their iPhone in order to connect. A lot of platforms, like regardless of what the patient's preferred language is noted as, will send that link in English. So they'll get an English link, even though they don't speak English, that says, it's time for your telehealth appointment. Please click on this link.
And we've had to like train our staff, like educate the patients. They're going to get this text in a language they don't understand around time of their appointment, and they need to click on the link. And no, it's not, it's not like a cyber. So just kind of education. I wouldn't say it's reluctance to telehealth itself, but just educating our patients on what the platforms are we use and what's entailed in that. Because I guess that's another kind of thing I wanted to comment on, just making sure as we are moving more into telehealth that all of our platforms are linguistically competent, the same way that we're wanting to make in-person medical services across the board accessible to patients who are Spanish speaking.
Yeah, so I'm definitely much more community member based. However, in some of this capacity building within rural communities, we are beginning to have conversations with primary care physicians in particular who maybe could provide telehealth but are apprehensive. A lot of what we're seeing is that, especially in really rural communities, it's a family medicine doctor who's been there for upwards of 30 or 40 years as the practicing physician within the area, and they've never had to use telehealth before. They don't understand their patients not being able to come to them, or what are some of the benefits of telehealth, not only for the patient, but what are the benefits to that physician. So we're doing a lot of education there, education around the clinical staff, just like was mentioned, making sure that the capacity is there from your care team and your physician to put that together, giving them education to start to see some of those benefits, like managing blood sugars. You don't have to have that patient in office slot open every X number of weeks to check A1C or look at things of that nature. If you have these telemedicine appointments, it can increase the efficiency that they have within their clinic. It can decrease the number of visits of patients coming in just to ask one particular question that could have been done asynchronously through a patient portal or type of communication. So that's a big barrier that we work with when we're working with our rural physicians. Our rural community members, I don't necessarily know if it's an apprehension to telehealth or if it's an apprehension to healthcare as a whole. The people that are typically reluctant to use a telehealth platform or seek telehealth treatment are reluctant to see the doctor to begin with, whether that's a basic distrust of the system or any other reason. So a lot of what we look at specifically with telehealth is how can we use trusted grassroots community-based organizations as either educators, navigators, sites where people can go in and have a HIPAA compliant location with maybe some assistance accessing the platform, things of that nature. And how do we navigate that in a way that a person says, no, I'm not going to the primary care doctor. No, I'm not comfortable having a primary care appointment in my living room because of XYZ family challenges, but I am comfortable going to a church or something of that nature. In my previous job, we were using a Baptist on Mission Rebuild Center in the Rose Hill area of Duplin County. So again, far east, trusted community center with close ties to CareNet that was able to be a site that had the broadband infrastructure for a virtual telehealth appointment. In particular, those are mental and behavioral health appointments primarily, but it had its own private entrance. People could kind of come and go. There was no question of why someone's vehicle was there, much like using other places where if you see in a small area someone's car, you don't wonder why it's there. So things of that nature, how can we have those sorts of conversations? Build, like we talked about earlier, coalition building and getting these collaboratives of people together to build these networks so that the patient's apprehension can be mitigated a little bit because they're going to a place that they trust with people that they know who are going to help them get the access if they have the question to be able to get onto their appointment, and looking at it from a much broader systematic level. Public health background here, so all of that kind of comes into play for me. But how do we piece those pieces together so that we can work around some of that hesitancy that exists just in accessing medicine, whether it be in person or virtually?
Great. Steve?
I have a wide variety of thoughts, and I'll try to be succinct. So building on what Courtney said about access points and trusted locations, When I first joined the Bakersfield Clinic back in 2006, I sort of restarted 2 clinics that were at K through 8 schools in the far northern end of Mitchell County, almost on the Tennessee, almost in Tennessee. And these were clinics that had been operated with grants from the Office of Rural Health to improve access to care. And I ended up for 5 years having a day a week at each site, seeing both kids in the school and people from the community. The county decided to close those schools, and because we were taking advantage of the county's resources to keep the practices open, the practices closed as well. And in Beulah Dean, for the following 10 years, patients would approach me and say, when are you coming back to Beulah Dean? When are you going to reopen that clinic? And through a series of events, a community foundation bought the old school, and the Center for Rural Health Innovation was able to open an access point there at that school where all of our providers are seeing people. And the thing that really has made it successful, and not just be a drop-in, is that we have a former paramedic from the community who is the telehealth presenter. And she's trusted, she's a Garland, and Garlands go back in the Beulah Dean area for 6 generations. So she knows everybody, and that is absolutely amazing. People who would never think of using telehealth are coming to the Beulah Dean practice to be seen. The other part of this is physician acceptance and and healthcare providers across the board. I wasn't trained in medical school, or I wasn't trained in residency to use virtual care. I don't know if I should be doing it. There was a movement pre-pandemic to make a medical specialty of telehealth, and I thought that was ridiculous. Telehealth is a tool. I don't have a specialty in stethoscope, so I don't see a reason to have a specialty in telehealth. But primary care physicians get bombarded with offers for a new platform. You've got to be doing telehealth. What are you doing? And I have a lot of conversations with groups that are thinking about telehealth and like, well, we have a platform selected, but no idea about how they're going to use it and how they're going to change their practice. And what we really need to see in the use of virtual care across the board is not substituting the in-person visit with a virtual visit, but evolving how we provide that care. And selecting the platform, the technology is the easy part. It's the workflow, it's the partnerships you need to build to really make this successful. And I feel that that's where the focus so often needs to be. We're building the body of evidence to support telehealth in many situations. Historically, it's really been vendor driven. Well, our product's been shown in this small study at a rural health center with 30 patients to reduce blah, blah, blah. And that's really not great. There are now large multi-site trials going on looking at the use of telehealth to demonstrate that it is of value and it's reducing ED utilization and bending that cost curve. And regardless of who's providing that care, if it's a clinical pharmacist or a peer support specialist, just that increased access is having an impact on cost of care overall.
Kevin?
Steve, I want to piggyback on something you said in response to the question, and that's is teaching. It's from a therapist point of view, psychotherapist is teaching our psychotherapists as well as our patients not only how to use the technology, but just understanding and using it as a tool, as a therapeutic tool. And we've certainly seen challenges in that. And in many ways. And so one thing we learned is that our providers did need a certain level of education of how to use telehealth as a tool, and not only compliance issues that came along with that and ethical issues, but also practice issues. And so as we've evolved, we've certainly incorporated more technology into telehealth, especially in working with kids and doing things like play therapy and using tools that are built into the telehealth platform for drawing and responding If you guys have ever attended a virtual training, which I'm sure you have, we all have at this point, right? The ones that are really good have the interaction, right? They have the live interactive elements to it. And so that was a bit of a learning curve for our providers, is training them and teaching them how to use those interactive tools to enhance the therapy, but also teaching patients too, because there's multiple platforms that we use depending upon internet accessibility and bandwidth. And so, that limits what we can and can't do. To the original question, just of, was there comfortabilities to be developed in the beginning? I would say certainly in the beginning. It was a pretty steep learning curve. I would say for our patients now and providers, it's becoming the norm. And so I don't see as much hesitancy to access. We still have a number of patients that specifically request face-to-face, and I think that will continue. But I have also seen, and our demographic data for who's utilizing telehealth the most, it mirrors, John, your slides, it mirrors North Carolina Medicaid data. If I break it down by age and demographic data, it's our younger folks, our teens, our late adolescents, and our working professionals. That's where we see it utilized, so far as demographically the most. I had a thought and I lost it. So I'll give it back to you. How about that? Yeah.
So we have one last question, and we've got 10 minutes just to let you guys know for that. What is needed statewide, regionally, or locally to support our telehealth efforts? Emily, start with you.
Yeah, thank you. So I think everyone can agree, like some of the things that we need, like especially in the really rural, isolated areas, better connectivity, better access to high-speed internet. We need greater education of patients, especially those who are in the most underserved, most vulnerable populations, making sure that they have the tools, the education, the equipment they need to access these services. I think everyone in this room, I think we can all agree on that. What I'm not seeing talked about yet, and what I would really like is, as a nonprofit, I think a lot of the organizations that serve some of the most vulnerable populations, free clinics, nonprofits, community-based organizations, we operate on very, very limited funding. Like one of our biggest challenges is we as a free and charitable clinic, we have access to an electronic medical record that is free to us because it's been shown electronic medical records like just increasingly improve patient outcomes. Now that telehealth is becoming so important, now that you could say like access to telemedicine is almost a patient right, and is like a social determinant of health, I would say, for many of our patients who like physically can't get to the clinic. Why wouldn't we then make it like a responsibility to provide affordable, HIPAA compliant platforms for organizations to be able to provide telemedicine services that are accommodating of patients who don't speak English, accommodating of patients who might not have a US phone number, just making those more accessible, like for supporting the organizations that are providing the telemedicine services to provide those telemedicine services in a HIPAA compliant way. Yeah, that's what I feel like we as an organization are missing and really need support in to make telemedicine, to do it the right way and make it accessible to our patients, that kind of support.
Courtney?
At risk of sounding like a broken record, I think the infrastructure for broadband connectivity in rural communities in particular is, a non-starter for what we need to continue this transformation and make things like this happen. I live in rural eastern part of North Carolina. The wind blows too heavy. Somebody else is on the phone. Something else is going on. I can't get on a meeting on my video because I'm constantly buffering, and I have access to relative quality of internet. But that's a frustration at my point with the access. What does that look like for somebody who doesn't have the access? And also within that, how do we make that affordable? How do we make that something that people can pay for month after month, so that they can continue to have the access? How can we look at it from that lens? What does that look like? Does that look like any number of methods? I don't know the best way to do it, but looking at it that way. We also really do need to look at the education lens. We can bring broadband infrastructure into every single community in this state, but if people don't know how to use it, don't know how to access it, don't know how to navigate it, and ultimately don't trust it, it's a wasted effort. So there's a lot of these issues of access that brings it in, whether that's affordability or availability, but also how do we use it? And how do we begin to put all of these pieces that seem maybe to often work in silos together so that as things progress, we can put these pieces together and make it a whole picture for our patient population in rural areas instead of a disjointed segmentation of an effort to do this work.
As I think about moving virtual care forward, I think that there are two parts that stand out to me. The first is quality of care. And since I was part of the group that wrote what the AAP has adopted as their pediatric telehealth guidelines, and it says pretty clearly, you shouldn't prescribe antibiotics for an ear infection if you can't see the ear. And so you need to know the limitations of the platform that you're using. And expanding on that idea of quality of care and sort of patient safety, I don't feel it's appropriate to provide isolated care as a telehealth provider if I don't have the ability to make a warm handoff or a referral to someone and move that person to a higher level of care. For example, I'm seeing a community member in Louisiana and they tell me that they have suicidal ideation and that they're hearing voices. That's something that telehealth in the setting that I'm using it isn't the best tool, but I know how to contact the mobile crisis unit in their community in, Pierre Plate, Louisiana. I'm sure I slaughtered how you say that, by the way, but, and get them to the house for support of that community member. And too often both the large telehealth corporations and also less ethical providers just say, go to urgent care. I'm sorry, we don't treat that, go to urgent care. And that's not good medicine. I wouldn't do that in my own practice. I would call the emergency department and say, John's on the way with a heart attack. And we shouldn't assume that you can provide less quality of care just because the access is easier. The other side of this is policy. And fortunately in North Carolina, I was part of a group that started rewriting Medicaid telehealth policy in 2019, right before the pandemic, and worked with the North Carolina DHHS to really modernize the policies there. We now allow FQHCs to be the distance site where the provider sits, and that was prohibited previously. So some great improvements there, but we need to continue on this policy journey where we really look at, there are concerns about controlled substances being provided via telehealth. I think it's totally appropriate for me to prescribe a stimulant to a kid in an elementary school for ADHD. I should not be prescribing narcotics to someone with chronic back pain who I've never seen in person via telehealth. And the FDA has kept pushing back changing the regulations around prescribing controlled substances via telehealth. And hopefully they'll actually come down with an opinion in October. They've pushed it back like 3 years. That's a whole different conversation. But there are other policy pieces that we need to be considering around digital health equity, around digital health literacy. How do we say if an insurer is reimbursing for telehealth, they need to help support that patient having access to telehealth services?
Thanks, Kevin.
I'll name three things. So one, I would say a comprehensive broadband expansion plan in rural areas. Second one, I'll echo what's been said around policy. And North Carolina Medicaid policy really knocked it out of the park and is a great example to go by. And so I would advocate for uniformity around telehealth, because what North Carolina Medicaid does is not what Medicare does, and it's not what Blue Cross Blue Shield, and it's not what Cigna or CBHA or MedCost and every other insurance company you can think of does. The rules are different everywhere, especially around what Medicaid did a really good job with of labeling what they label as distant sites where the provider sits versus originating sites, which is where the patient sits, and all of the regulations associated with that with each specific insurer. So some uniformity, and I'd say some parity as well. So far as what insurance companies are covering. I've seen some Medicare Part C Advantage plans do some interesting things with telehealth as to what they are charging or not charging patients versus face-to-face. And there just seems to be a bit of a fairness issue there. And so I'd argue for parity. And last thing, in my profession of psychotherapy, there's been some professional organizations with specific psychotherapy license that have done a really, really good job with interstate compacts of allowing psychotherapists, especially looking at that slide of the need for behavioral health care is just is so much higher than all these other areas. And but allowing for interstate compact to allow psychotherapists to see folks across state lines and creating some still regulation and some jurisdiction around that. The licensed clinical mental health counselors in North Carolina, their professional organization has done a really good job with about 7 other states that allows for interstate transfer, interstate compacts of providing services across state lines. And so I'd love to see some of the other professional organizations like the National Association of Social Workers, Licensed Marriage and Family Therapists, and APA, American Psychological Association, and even Psychiatric Association form some expanded interstate compacts to allow for this work to continue, especially in context to the mobile culture that we are, and aligning it with the mobile culture of telehealth. It just makes good sense.
Great. Thank you all. The wonderful responses, varied responses. Ellen, there we go.
Here.
Okie doke.
All right, so now we're opening up to questions from everyone, and it looks like we've got a few. I know my brain is spinning. I don't know if anybody else has a 86-year-old grandma who was crazy even before she got dementia, but would love some more telehealth access for her. So I'll pass it on to him.
Thank you. Hi, everybody. I'm Brian Rathbone from Broadband Catalyst, and there is an effort going on right now nationwide, but we're specifically working with North Carolina to identify community anchor institutions. There's money to hook up those CAIs with gigabit symmetrical capable connectivity, and we've been looking at rural firehouses, looking at pharmacies that have a dedicated space for telemedicine, those types of things. I would just love any insights that you have, because honestly, we're having trouble finding them and identifying them. So if there's a central database of telehealth providers, that would be useful to know. And I'm just curious as to what your thoughts are about enabling community anchor institutions, community centers, those types of locations, and utilizing them, because it's going to take a while before we have sufficient broadband for those areas.
So providers of telehealth, the Telehealth Resource Center, specifically the Mid-Atlantic Telehealth Resource Center, has a mapping tool that they're using to try to document where telehealth services are available, because it changes so rapidly. It's hard to say that it's up to date, but matrc.org is where to look for that. The firehouse idea, volunteer fire departments, I think, are an amazing opportunity, because at least in my community, there's one every 10 miles. The first responders who are there would be great telehealth presenters, and they know when to say, you know what, this isn't appropriate, let's get you somewhere better. So connecting broadband there, and it's people from the community that are trusted. So I'm a huge advocate for that and have been for a while, saying that that should be something we look at. Libraries are another great source. Who's the presenter in that setting? The attempt to use virtual kiosks 8 to 10 years ago kind of collapsed due to cost. Cleveland Clinic was backing a company and it failed. There may be new efforts into that. There are a couple of platforms that do it, but that's going to be a barrier to access. You want me to check my own blood pressure? You want me to hold the stethoscope where? That may not work as well, even though you're under the direction of a medical provider. Yeah.
One thing I'd also respond, we've been working with libraries in particular and have worked with a lot around the country. And one of the things that is pretty commonplace is simply opening a telehealth resource in a library is insufficient. People won't show up, they won't use it. And libraries are constrained for HIPAA reasons and other reasons in terms of actually providing care. So to make it successful, it's very important that the libraries work directly with healthcare providers who actually provide referrals to that site. And that's true for any other access point that's not a healthcare facility or organization. Any other responses? No? Any other questions? Oops.
Yes, right here. In the virtual world, there's an individual named Karen. She's hopefully watching. Another individual named Susan. Karen is a retired nurse. She has formulated an elder nurse corps. These are people 60 plus years old, still active licenses. They want to assume a stewardship in their community. That's Karen's world. Susan has 67 community centers in Western North Carolina. Many of them are lighting up or already have high-speed broadband. What is a simplified process or a model to implement the resources of a community nurse that knows the community, is still licensed to help in this scenario?
A simplified source doesn't come to mind.
It's not easy because all of the people who go to that community center don't have the same medical practice. And so, do they want to see their own healthcare provider, or is there a larger entity that provides acute care and sends those notes back to their primary care provider? Also, what's the demand? When we first opened our school-based telehealth program, we thought that we could do 3 mornings a week and it'd be great. We'd get lots of utilization. Well, kids are really only sick on Tuesday afternoon, never Monday, Wednesday, Friday between 9 and 12. So how do you make sure that you have access when it's needed? Licensure is not a big issue. Payment maybe. Is the medical provider who's agreeing to take a slot that day enrolled in the insurance that patient has? And what are the use case scenarios? It's a beautiful idea. I'd love to think through it with you because there are definitely solutions out there. And it's not going to be the same solution at all 67 sites.
Yeah,
Sorry.
I completely agree. It's an intriguing idea. Is this a hypothetical or is this actually a real situation? Okay. I'd love to talk with you afterwards. Again, it's not a simple solution, but it's got legs. So it's worth talking about. Doug?
Okay, there you go. So, yeah. Okay, my question's for Emily. You talked a little bit about language access and patient portals. You talked about how the message would come in English to get on the link for the telehealth appointment. Can you maybe talk a little bit more about access to patient portals for the patients that you work with and like some of the challenges and maybe some benefits you've seen as well?
Yeah, absolutely. So you're asking about patient portals? Okay, so we have had a really hard time getting our patients to utilize patient portals. We honestly, I don't think we really try anymore. A lot of our patients either don't have an email or the portal that our specific EHR creates, it makes like their visit notes accessible, but those visit notes, like the providers write those in English as well. So if we do have a patient that is has an email and is, tech savvy enough to access their portal, see their results and whatnot, everything in that portal is not in their primary language. So I'm going to be totally honest. We've looked at like pushing the patient portal in the past with our patients, even like creating like a handout that really like walks them through how to like register and use it, but we haven't
we haven't really pursued it. And that might be specific to our EHR. I'm sure there are patient portals out there that are, based on what the patient marks as their primary language in the EHR, able to produce, communicate with the patients in Spanish, but our EHR is not capable of that. So I feel like I have limited response to that question, just because it's been a challenge for us. And I don't know if other organizations, if there's any healthcare organizations, if y'all have experience with your Spanish speaking or non-English patients and the patient portal. But it's a huge, I feel like we're losing a huge opportunity there, because we do have a lot of patients who, the migrants especially, because they are so migratory, because they might come back to this area to work next year, they might not, they might be down in Florida and have some kind of acute issue, and the provider down there has no idea what their medical history is, has no idea what lab work they've already done here. Things like a patient portal make it so the patients themselves can have a copy of their results. They can access it while they're in Florida, while they're in Mexico, they can access their results, show it to their provider down there and say, this is what they did for me at Vecinos in Cullowhee, North Carolina. This is what I've got going on. So it's a real lost opportunity. But I don't know if anybody else in the room has experience with patient portals outside of English speaking patients.
Anybody else have any thoughts? No? Oh, is there? Just a second.
I work in affordable senior housing, and we did a big push starting during the pandemic to get our residents to use telehealth, and the portals, and these are primarily English speakers, the portals are a huge obstacle even for them. So I don't think it's just a language barrier. I think it's also a comfortable with technology barrier, and they don't have emails. We have to try to set up, to get them into telehealth portals, it took a lot of social work time.
It's a big barrier in any practice, and the challenge is that HIPAA won't let us text. And so you need to use a separate software platform, because if we could text with our patients, it would be a whole lot easier to deliver this care. And so there are platforms that do it, that merge with your EHR, but that's another barrier, a cost that the practice needs to assume, so limits adoption.
Yeah, honestly, after the COVID pandemic and the HIPAA kind of being a little bit more flexible with telemedicine, our providers got used to being able to use telehealth and being able to use telephone and being able to use these platforms that patients were comfortable with. So now I have a really hard time even trying to push my providers to use patient portals, use the HIPAA compliant platforms, just because there is such a barrier with even just a patient. Anything that requires a patient to download an application on their phone, forget it. Anything that even just something like the text and the link for a lot of patients is not super accessible. So yeah, it's a big challenge. And I think you're right. I don't think it's just a language barrier. I absolutely agree.
Kevin?
I'd also say, being part of a large health system, right? We create some of that culture. And, we are not allowed, from a HIPAA compliance piece, we can't text, we can't email. Everything has to flow through the EMR. But there's also policies, and there's also incentive payment systems, and there's also accountable care organizations that in order to participate in it, you have to utilize that technology, and you have to give patients access to it, and the patients have to use it in order to communicate with you. So there's a piece of the culture of even just healthcare that we likely create and exacerbate that problem too. Yeah.
There's almost like a cultural shock cultural clash between our medical culture and the culture of some of our patients.
Any other questions? All right. Ellen? Oh, here we go.
Hi, Jeff Searle, Searle Consulting. So since we're talking about portals, I don't like them either. And so I just thought I'd add that. And English is my first language. You have 3 different providers, 4 different providers. You have 4 different portals, passwords, etc. So I thought I'd pile on since we were all piling on. But my question has to do with affordability. Any thoughts on how
we could wrap reimbursements into the system to allow for the subsidization of the access. So if you are maybe low income, it's difficult for you to afford a broadband service, pay your broadband bill, but you need a telehealth service, maybe combining the two.
Go ahead.
I know we tend to see policy trending in this direction of subsidizing certain things that are necessary for medical treatment, be it nutritious food with certain Medicaid plans or things of that nature that are starting to come to the forefront. I think there's space for it. I definitely think that it could be something that could be worked in. I think it may be something that might be more easily accomplished in a private payer situation. Private payers might be more happy to change some of their policy rather than a public payer where things have to actually go through legislature and things of that nature. You're starting to see those things happen in Medicaid. You're starting to see those things happen with Medicare supplements that allow for some of these things to be subsidized. I think if that becomes a little bit more mainstream, then going to a private payer might make it a little bit easier to pick up. Again, at risk of sounding like an advocate, I kind of have to be very careful with what I say. However, there is a trend, in particularly in North Carolina, towards it. I just don't know how quickly we're moving in that direction and how something like that at a grander scale could become a possibility.
So I can fill in the blanks that Courtney can't because I'm not a state employee. So North Carolina Medicaid, as part of transformation, built the Healthy Opportunities Program. And Healthy Opportunities currently provides, it's a pilot right now, and currently is providing direct insurance reimbursement to community-based organizations for food, domestic violence or interpersonal violence, transportation, and housing services. And this is the model I think we use, where I as a physician can write a prescription for a healthy food box. I as a physician can write a prescription for telehealth access or remote home monitoring, and the insurer pays for that. And that's where I think that we need to move. We're already seeing preliminary data on the Healthy Opportunities Program that it is bending that cost curve, saving about $86. The original data out of Duke and the Shep Center said $86 per enrolled, per user per month is being saved. So I think we're going to see more ways to get to that. And private insurers have interest in addressing drivers of health through funding because they know it's cheaper than a $6,000 ED visit.
All right. Well, thank you all so much. If y'all give our panelists a thank you for being here.